Unfolding the Pathophysiology of Congenital Thrombotic Thrombocytopenic Purpura in Pregnancy. Lessons from a Cluster of Familial Cases. Thrombotic thrombocytopenic purpura is a rare, potentially life-threatening thrombotic microangiopathy, often associated with renal failure and neurologic manifestations. Both congenital and acquired forms of this disorder are caused by the severe depletion or absence of ADAMTS13, a critical enzyme responsible for the cleavage of von Willebrand factor multimers present in the circulation. This results in accumulation of ultra-large von Willebrand factor multimers and extensive platelet adhesion and clumping with possible secondary end organ damage, including renal failure and neurologic symptoms. Pregnancy can provoke the clinical manifestations of both acquired and congenital TTP in first-time patients or can exacerbate its recurrence. 12 to 25% of TTP cases are diagnosed in relation to pregnancy, and 75% of TTP episodes occur near the time of delivery. The increased risk for developing TTP during pregnancy may be due to physiologic changes, which lead to a progressive hypercoagulable state throughout the course of the gestation, with the greatest changes occurring at term. In TTP, variants of the ADAMTS13 gene lead to depletion of this enzyme. While the reported prevalence of the familial form of TTP is rare, the actual prevalence may be underestimated, as suggested by a recent report in which 24% of pregnant women who developed TTP had the congenital form of the disease. In a previous report from our group, a novel mutation of the ADAMTS13 gene was identified on chromosome 9, coding exon 28 C3772 deletion A, which results in a frameshift mutation leading to the depletion of the ADAMTS13 protein and development of CTP. All patients presented in the study belong to two closely related families of Arab Bedouin descent, who in a previous report published by our group were found to be homozygous for a novel ADAMTS13 mutation. Patients were identified through episodes of microangiopathic hemolytic anemia and thrombocytopenia. Patients circled in red include the patients who were taken for a follow-up study presented here today. In this report, we focus on pregnancy outcomes, placental histology, and response to treatment. 19 women with TTP were identified. Of those, 1 was identified as acquired TTP, while the additional 18 women were all homozygous for the unique novel ADAMTS13 variant identified by our group and were diagnosed with CTTP. Of them, 16 women were included in the study, and 2 who had never been pregnant at the time of diagnosis were excluded. Of the 16 women that were included in our study cohort, 13 were diagnosed following a pregnancy with obstetrical complications associated with CTTP and had heterogeneous clinical presentation and course. The remaining 3 patients had previous pregnancies and deliveries. However, they were diagnosed with CTTP due to complications outside of pregnancy and at older ages. We divided the presentation of clinical complications into 2 subgroups. One subgroup included the women diagnosed following pregnancy complications in blue, and the second included women diagnosed outside the context of pregnancy at an older age in red. In patients diagnosed following pregnancy complications, presenting symptoms of CTTP including recurrent pregnancy loss, stillbirth, early onset preeclampsia, both mild and severe, HELP syndrome, fetal growth restriction with abnormal Doppler flow, and preterm pre-labor rupture of membrane. 4 women presented with more than one complication. Amongst the 3 patients who were diagnosed due to complications outside of pregnancy and at older ages, presenting symptoms included CVA and thrombocytopenia. However, all experienced CTP in pregnancies which occurred 10 to 20 years prior to diagnosis of the novel ADAMTS13 variant, and they all delivered their pregnancies preterm between 27 and 34 weeks of gestation due to TTP or preeclampsia. In addition, 2 of them had late miscarriages at 14 and 16 weeks of gestation. Neonatal outcomes of the index pregnancy are seen here. Amongst the 13 fetuses delivered, there were 7 males and 4 females. The mean gestational age at delivery was 33 plus 3 weeks. The mean birth weight was 2,005 grams. The total perinatal mortality was 30.7%. The rate of antepartum deaths was 23% and postpartum death was 7.7%. Follow-up pregnancies. Following diagnosis of CTTP, 9 of the patients had 21 subsequent pregnancies. Throughout 17 of the aforementioned pregnancies, the women were transfused with FFP once every 2 weeks until 20 weeks of gestation and every week thereafter until delivery. Amongst the pregnancies that reached fetal viability, treatment resulted in a 100% fetal survival rate and was associated with a reduction in the overall number of complications. However, the response to treatment varied among patients. Following biweekly FFP transfusions, 41% of the pregnancies were normal. 2 had mild complications, including SGA and mild preeclampsia, and 4 had severe complications, including placental abruption, severe preeclampsia, severe gestational hypertension, and HELP syndrome that required indicated preterm birth. 1 patient developed severe ARDS following FFP transfusions that required indicated preterm delivery. 3 pregnancies in women with underlying thrombophilia ended in miscarriage. We are able to collect 28 placentas. All the placentas had lesions consistent with maternal underperfusion. The most frequent lesions identified included intervillous fibrin, syncytial knots, avascular villi, and subchorionic fimbrial thrombi. The relative proportion of all these lesions decreased among the 8 placentas of pregnancies that were treated by fresh frozen plasma. In this figure, panel A demonstrates histologic findings from an untreated pregnancy, including intraplacental infarcts, red arrows, groups of avascular villi seen by the black arrows, focal excess of syncytial knots, subchorionic and intraplacental fimbrial thrombi, and intervillous fibrin deposition, blue arrows. Histological findings from a placenta of a pregnancy treated with FFP in the same patient includes well vascular villi, green arrows, with no infarcted villi. Principal findings. This report presents a case series including 16 women who carry the novel ADAMTS13 C3772 deletion A variant associated with congenital TTP and had complications during pregnancy. Following diagnosis, most patients were treated with biweekly fresh frozen plasma infusions that appeared to substantially decrease the rate of pregnancy complications. Placental histology revealed maternal vascular underperfusion as the possible underlying mechanism of disease leading to pregnancy complications in these patients. There were 21 ensuing pregnancies subsequent to diagnosis. The 17 that were treated with FFP responded well in the majority of cases. The available placentas from treated pregnancies suggest that treatment with FFP may reduce the frequency and intensity of the placental vascular disease in these patients and improve pregnancy outcomes. In conclusion, our findings imply that the variant identified in the ADAMTS13 gene in our cohort may have a predilection for the placenta, and treatment with fresh frozen plasma during pregnancy ameliorates the course of the disease, resulting in a milder phenotype or a normal pregnancy in the majority of cases.